What's going on, everyone? Welcome back to another episode of the Muscle Memoirs Podcast. Today, we have a magnificent episode for you. Joining me across the screen, Dr. Karl Nadolsky. Dr. Nadolsky, how are you doing?
Doing all right. Thanks for having me.
It's my pleasure. I'm really excited to get into our topics of discussion today. But before we do so, could you give the listeners a little bit of background about yourself?
Yeah, I am an endocrinologist, board certified in diabetes, endocrinology, and metabolism. Also, diplomat of the American Board of Obesity Medicine. I went to Michigan State for undergrad, was on the wrestling team there, had a good career. And that's part of what got me into, performance, nutrition, fitness and stuff. And then how to bring that to the population at large is kind of what got me into medical school, and then did my internal medicine residency actually in the Navy at Portsmouth National Military Medical Center there, and then did my endocrinology fellowship at Walter Reed National Military Medical Center in Bethesda, Maryland, across from the NIH. Spent a couple of years as faculty, and then moved home to West Michigan, where I'm part of a big tertiary, or actually a quaternary care hospital system here with our endocrinology department.
Fantastic. For the listeners of the Muscle Memoirs and the guests they like to see, you're definitely checking all of the boxes. And for those who are listening on audio only, I pity you because you don't get to see the phenomenal background that Dr. Nadolsky's rocking for the Docs Who Lift brand. I do really enjoy it. Dr. Nadolsky, something you've been putting out on social media recently. I'm sure it's generated a lot of controversy for yourself. It's something that I love. I want to open up our discussion today with generally talking about functional medicine, the emergence of it, the fact that it's growing in popularity. As a young dietitian myself, kind of similar field, but functional nutrition is something that I hear about on a regular basis. I get told by other practitioners in the field that, hey, you're young, you are new to it. You should get on this horse now while you can. This is the future. Functional nutrition, functional medicine is going to be driving this space. And you've been outspoken about this area and saying that more or less functional medicine functions as a Trojan horse for quackery. I think that's phenomenal, but I would like you to expand on that for the listeners.
Well, and so it really kind of comes down to, how it's defined and portrayed to you. So actually, I'd be interested to hear from you maybe about what people who have suggested that to you, how they define that to you. And then I'll kind of go from my end.
Very generally, right? So this whole premise of functional nutrition, functional medicine, it's the superior realm. It's the future because it does a better job of getting to the root of the problem, right? I mean,
so here's my question. So why though? Why and how? And how is that different than what was taught to you and how everyone is already supposed to be trained? So here, you basically answered me what I needed to know in just 5 seconds. So, so you went through school. I went through undergrad, went through medical school, went through internal medicine residency training, did extra training beyond residency in school to get certified in obesity medicine, then went to fellowship. And doctors have to do continuing medical education all the time to do the best we can to stay up, which is easier said than done, right? You guys have to do that. Everyone has to do that. Where I never, ever heard anybody in medical training, nutrition training, who said, you know what? We need to just be very superficial and only treat the symptoms instead of getting to the root underlying cause. That's the most obvious fundamental teaching that goes way back long before we were ever around in medicine, nutrition, and health. We always want to evaluate holistically using the real definition of that term and get to the root of the problem. Let the body heal thyself, right? That's the bottom line philosophy, finding a way to help the body heal itself and that sort of thing. And that's what we all do. That's what healthcare is about. Now, that doesn't mean our healthcare system is good and does a good job of that. That's a whole different topic. We all have to find a better way, and there are bigger obstacles there. But the philosophy of it has always been that. So then suddenly comes along these different sort of marketing terms, and one of them has become integrative or functional medicine. And it's marketed as, oh, we actually, we know the truth. That's always a red flag of quackery. When somebody knows the truth, because in science and healthcare, there are no secrets, other than people that haven't published something yet, because that's a special thing, right? But basically science gets published and peer reviewed and debated and discussed and then reevaluated, because we all want to know, we all want to help treat the underlying cause, get to the root of the problems, help people out. And so when they start saying, oh, well, the truth, and we're, those mainstream doctors and dietitians and nurses and everything, they're just covering your symptoms. They're just putting a Band-Aid on it. We'll actually get to the root of the problem. Oh, but by the way, give us all this money for a bunch of supplements that don't actually do anything and get to the, and then they make up terms. Well, then that's just an obvious red flag of quackery, but it's not so obvious to lay people who, maybe have been scorned by our dysfunctional system that we all have problems with. And, so there are reasons why it's an easily marketable thing. And there are physicians and dietitians and others who have been swayed, not because they're malicious. They've been, maybe they're benevolent. They're like, oh, you know what? That's true. I need to do that. And then they get educated by these, sometimes fake things that turn out to just be marketing. Some, I'm sure, are doing it maliciously, but I think there are a lot of people that are trying to be benevolent. They're like, oh, you know what, that sounds right. Yeah, it's good. But really the way that it's marketed and defined and suggested is how we are all taught, or at least supposed to do it. We're all supposed to be evaluating people holistically, getting to the root of the problem and trying to do what's right for the patient.
I mean, ultimately, it's a complete straw man, right? It's just they're
Yeah,
putting out
right.
there, they're putting out there that the mainstream doctor, dietitian doesn't try to get to the root of the problem. And like, of course, there's always going to be practitioners in the field who are below average, right? And for some people, they might run into a doctor who, they are just trying to push some pill on them before a lifestyle intervention to control the symptoms, quick and easy, get in, get out. But that's not the majority, right?
And by the way, it goes the other way around. And so we all are different and have different relationships with patients, right? So I like to think that everyone loves me and I do so well with everyone. But you know what? We see the responses, right? We get feedback. And I've had patients say, I don't like Dr. Nadolsky. He tried to get me to eat better and exercise, and he knows I can't do that stuff and whatever. So it goes both ways, and that's okay. We're all different. We all can provide different personalities to patients and try to help out the best we can within the confines of our often dysfunctional system that is really more of the problem. And going back to the functional integrative thing, the unfortunate part about that is it's like a divide and conquer. You're right. So there's no need to have that. We all should just be functional and integrative and doing all that stuff within our whatever specialties we are. And instead of like dividing and conquering, saying, oh, those guys don't know what they're doing. And then, of course, what too often happens, and why I say it's a Trojan horse for alternative medicine or quackery, is because then they start doing things that are inappropriate, making people pay money for things that are not supposed to be done, which I think you're going to ask me about in a couple minutes. And, and they do things that aren't right, or they say they have a disease that they don't actually have, but they're making them spend money on supplements that they don't actually need. And maybe they need a real evaluation. And that probably sets you up for some other questions coming.
It absolutely does. So let's get into those specifics. I mean, when I get clients who have maybe saw, a functional practitioner, whether it's a doctor or a dietitian before me, and they tell me some of the things that they've been incorporating since, or the diagnoses that they've gotten, to me, it seems like a lot of the time that functional practitioners are almost like they're trying to make problems for the person to a degree. It's utilizing pretty much excessive testing, just trying to make the person feel like that there definitely is something wrong with you, and that I have these alternative tests that are going to get there. But it seems that they're rarely substantiated by the evidence, which leads me to a couple of specific topics. And the first one I want to start with is adrenal fatigue, which it seems to be dying off. This was like a more popular no, okay.
And not for the endocrinologists who get the referrals.
Well, that's very unfortunate. So with that being said, Dr. Nadolsky, tell us, why does adrenal fatigue exist? Why has this become like a mainstream topic? What is it supposed to, what criteria fulfills this diagnosis for someone?
Well, that's the thing. There in real life physiology and medicine, there is no such diagnosis, and there are no criteria. It's and I actually pulled up an article from from Endocrine Practice. This was pretty recent, from 2019 or something, and it goes through the history a little bit. It's an article entitled "Making a Difference in Adrenal Fatigue." And it's actually by an endocrinologist who talks about how so many people use this term that we have to do a better job of talking to people about it. Because if we just say, adrenal fatigue's not real, get the heck out of here. Well, that's why there's a problem, right? Then they go to the people who market it, and then they buy their supplements and all that stuff. So according to this author, the term was coined in the 90s by a chiropractor named James Wilson. You've heard of Wilson syndrome and all these other things. And cites that it's loosely defined as a weakening or burnout of the adrenal glands in response to chronic stress. So, if we talk about our hypothalamus, the area there in our brain that controls a lot of our stuff, it's our heat, metabolism, appetite center of control. And then it tells our pituitary gland to do a lot of its master gland stuff, which gets into a lot of the hormone glands that people are pretty familiar with: thyroid, testicles, ovaries, adrenal glands. And so, we have something called ACTH. I tell patients it's like the cortisol stimulating hormone that goes from our pituitary gland to our adrenal glands. It makes cortisol. There are also some other hormones that our adrenal cortex makes, blood pressure hormones and sex steroid hormones. And then the middle of the adrenal gland actually makes what we consider adrenaline, the catecholamines. But really what adrenal fatigue is at least getting at, is the cortisol. That's our stress hormone. It increases blood sugars, makes us a little bit awake, makes us nervous. Too much is really not good for where we store our fat. It's not good for our bones. Too little is really bad for our physical well-being, our blood sugars, our energy, blood pressure, and stuff like that. So real adrenal problems, from hypothalamic or pituitary injuries, tumors, things like that, or with the adrenal glands, autoimmune disease, hemorrhage, bleeding, diseases in other parts of the world where there are infiltrative diseases or infectious diseases that cause those adrenal glands not to work, cause really, really significant problems, like really bad, like life or death problems. And people have to be on cortisol replacement therapy, essentially. And we have a variety of what we call steroids to treat that. And this is a huge deal, and you need extra for when you're under stress, especially if you're sick or having surgery or something like that. On the other hand, there are syndromes called Cushing syndrome, after a guy named Cushing who discovered these. And generally speaking, that can be from a pituitary tumor that makes too much of that ACTH, or cortisol stimulating hormone. That's Cushing's disease, or from an adenoma, or a growth on the adrenal glands, and then some other rare where both of them are doing it, making too much cortisol. And that's when, if you get symptoms, round red face, you get fat, around your shoulders up here, you store the fat in your belly, which is really, really bad for diabetes, heart disease type stuff. You get big purple stretch marks called stria. You get muscle wasting, bad for your bones, like I said, osteoporosis and fractures. But within the realm of normal physiology, we need our hypothalamus, pituitary, and adrenal glands to do what they need to do to kind of take care of us for all the stress and stuff that we're going through. So Yeah, high levels of stress, not getting enough sleep. And there are other conditions where we actually have physiologically elevated cortisol levels. Those are, not great, but it's not a disease. You know what I mean? And so when we talk about working on our diet, exercise, stress reduction, sleep improvement, all that other stuff, that is good for us in a ton of ways, very holistically, very functionally or integratively. And yeah, and it has some role to do with our cortisol, but it's all working together, right? Um, and what's ironic about how they describe adrenal fatigue is basically that chronic stress where we actually have chronically high levels of cortisol, not low levels. And the symptoms that they try to come up with for adrenal fatigue are actually the opposite. So really, more importantly, when people are being evaluated for fatigue, their symptoms are real. They have fatigue. They have whatever they're saying they have. So when someone says they have adrenal fatigue and tries to sell them stuff, that's not actually, ironically, addressing the underlying issue. They might have some significant medical problems. Now, maybe it is just all diet, exercise, sleep patterns, stress reduction, all these other things that we can actually work on very holistically with a health coach or even a naturopath or a psychologist, whatever, counselor. But they have to have a real medical evaluation for real causes. Sometimes they end up getting to us where maybe they do have an adrenal problem, but that's pretty dramatic usually.
Yeah, as you touched on there, most people probably aren't dealing with an actual problem with the adrenal gland. And, it seems like this is just people like to throw things in the boxes, right? They want an explanation. They want something easy. And it's just like, oh, I feel tired, at certain points of the day. Throughout the week, I just progressively feel more tired. And it's just like, oh, well, something must be wrong. Like that's adrenal fatigue. I mean, I can't tell you how often someone comes to me and they're like, oh, my energy's low. Like, 3 p.m. comes around and I'm just ready for a nap. Like, I think something's wrong with me. And I'm like, I think you're human, and kind of like the natural circadian rhythm of being a human. Like, there's going to be peaks and valleys in your energy throughout the day. They're just like, how do I just be completely energetic and on the ball 24/7? And I'm just like, that's not how it works.
Right, potentially. And like
Yeah.
I said, so a lot of the patients, it's interesting. So we get referred patients who are being evaluated for fatigue. And I think part of it, because of the whole adrenal fatigue stuff, they end up getting referred to endocrine because people are going, hey, is there any hormone problem going on? Which is like the bane of our existence, right? But we help. And I end up doing a ton of sleep medicine referrals. You know how many people have sleep apnea? Not only from obesity, but just from, other causes, or they just have really bad sleep. Sleep's like the unsung hero. That's usually why people have to take a nap in the afternoon.
Yeah, absolutely. I remember we had on Dr. Jamie Tartar and more or less put forth that like sleep is the best free supplement on the market. People want to, put out $250 for supplement here or there. And
Yep.
it's like, if you just spent an extra hour or so in bed each night, like it would be remarkable the change that would have
It's a
compared to any
huge
other
deal.
supplement.
Yep. I always tell patients sleep is like the unsung hero of lifestyle, medicine. Diet, exercise, and sleep doesn't get talked enough about. And it's easier said than done, right? People are busy. We have stuff going on. The vicious cycle of obesity that causes sleep apnea that makes you feel worse. You can't do the, you can't eat, but it's, and that does get into cortisol a little bit. Cortisol goes up, but it doesn't mean you have a pituitary tumor or an adrenal tumor, or the opposite, where you have a deficiency.
Absolutely. The next thing I want to touch on here while we're specifically in this realm of functional medicine is another thing that seems to be increasing in popularity specifically, and that is the Dutch test. So I don't imagine that the listeners will widely be familiar with this test. So I guess we can start by outlining what this is.
Yeah, so certainly, I don't use this because it's not validated in medicine. And if you do like even a Google Scholar or a PubMed search, you won't see many things. Now, basically what it is, it's using dried urine to get the hormone metabolites. And I think there are several parts of it that are to some degree validated as far as like the actual lab assay part of it. The thing that people don't understand, though, when we start looking at labs, and especially hormones, is they have to be studied in very, relatively broad and specific ways to get consistency, to get our diurnal patterns and things like that, to figure out what's associated with disease, what's associated with normal, the normal reference ranges, how much off are the labs, what causes problems to the labs, what are the best. I mean, we have tons of labs that are validated for what they are. Using them the correct way in the way they've been studied is hugely important and is hard enough for doctors, let alone, whoever the heck is ordering Dutch tests, which usually isn't like real physicians. And so it's not so much about, well, does it measure the hormones? Because I think some of them do a decent job of that, if I'm not mistaken, but they haven't been validated in a clinical manner to diagnose any type of disease, pathophysiology, or problem. They just kind of measure a bunch of hormones randomly. And that doesn't help anybody other than for, integrative or functional physicians or others who are going, oh, look at this, this is off. And here you go, pay me some money to do something with it.
Yeah, I think it's easy to get distracted by these things because I guess from a business perspective, or even just generally wanting to be, one of the best practitioners and being able to serve your clients in an optimal manner, when you see other practitioners putting out like, oh, I used the Dutch test and, oh, look at this client transformation, and their messages from me talking about how they've been dealing with these issues for 5 years. And, we used the Dutch test, we got this comprehensive analysis, and it gave me this unique insight I couldn't get anywhere else. It becomes distracting to other practitioners. Like, what am I missing out on? Is this really something that I should be looking into to optimize my practice? But we need to remember, is this validated by any peer-reviewed published evidence? And as you outlined, that doesn't seem to be the case.
Right. And the other thing, and this happens in medicine all the time. Doctors, nurse practitioners, physician assistants, nobody's perfect. That's why we have specialists who do, more and more and get, familiar with certain things. But you have to, when you're going to order something, you have to know the clinical context. You have to know what we call the pre-test probability of somebody having something wrong. And then what are you going to do with the answer? So I can't tell you how many times, and I don't want to throw other docs under the bus, but this is the way it is, and we all do it. But, somebody orders something and then they don't know what to do with the result, and they refer to the endocrinologist or whatever the specialist is that deals with it. And so that's the thing with this. What are you looking for, and how is it going to change how you help the person? So generally, when we're looking for tests for, like, say, adrenal, for example, we either have a clinical suspicion to think they have adrenal insufficiency, and we have several ways that are validated to look for that biochemically, in addition to the clinical concerns. And then we have to know, what are we going to do about it? One, we have to know why. We can't just say, oh, all right, you got adrenal insufficiency, good luck with that. That's not how it works. They might have a pituitary tumor. They might have something going on with their adrenal glands. If it's an autoimmune disease and we dig in deeper and confirm and say, oh, this is what it is, then they need steroid therapy. They need cortisol replacement therapy. And maybe the other one, the aldosterone, if it's their adrenal glands that don't work. That's the blood pressure hormone. And that's the thing with the Dutch test. They do these tests, and then, I don't know what your feedback is on what they're doing about it. Are they giving them supplements that haven't been shown to work, or are they actually replacing their hormones that they might not need, and now they're spending money and potentially putting themselves at risk? Because you shouldn't take steroids, neither anabolic or glucocorticoids that we're talking about, if you don't need them, for sure.
Do you have an opinion on the potential future of the Dutch test? So while the evidence isn't there to validate it right now, do you foresee, possibly the evidence emerging for certain aspects to be useful, or no?
It's possible. I think, again, it depends on, it would have to be studied for specific pathologies, for syndromes, looking for something that you can help and diagnose and treat. And again, because I've been asked about this a few times, so I've tried to look, and that's why I think some of the tests are somewhat legitimate as far as like actually working and finding a level of a hormone that correlates to something. But then it would take a lot more testing and validation for them to be useful in real clinical practice, but it's possible. I mean, so one thing that people, functional docs or naturopaths, whatever, use for adrenal fatigue is they do these salivary cortisol measurements throughout the day. Now, one problem with those is they often use labs that are not actually validated and consistent and up to par. But one of the best ways that we have for checking for Cushing syndrome or Cushing disease, especially, is essentially a midnight salivary cortisol. And again, there's a lot of caveats. It has to be done correctly with the right pretest probability and clinical context, because your cortisol should be low in the middle of the night. And so because of that diurnal rhythm, it's been studied to check that at that time. And again, they have to have reasonable sleep patterns and all these other things. It has to be the right situation. But that's one of the best diagnostic tests we have for Cushing's, too much cortisol. And then on the other hand, your cortisol should be high first thing in the morning when you wake up. So we have a variety of ways to measure, morning cortisol and ACTH, and we do that in the blood usually. But then there's some other nuances and imperfections, by the way, even with the good stuff. So it's possible. Yeah, it just has to be figured out how it can be, correlated. And I'll let the bench researchers and then the clinical researchers figure that out, and then I'll return to it if necessary, if possible. Because doing a dried urine test, that would be nice for people. It's kind of like a salivary thing.
Hey guys, Mike here. If you're interested in learning more about how to maximize your health, body composition, and performance, head over to hammerawayfitness.com, where you can sign up for coaching or even just schedule an hour consult with me to get some of your training and nutrition questions answered. Also, if you enjoyed this episode as much as I did and would like to further support the growth of the Muscle Memoirs podcast, you can give a donation to the link in the show notes, leave us a review, and or share this episode with your friends, whether that be dropping the link in a group chat or putting a screenshot in your Instagram story. I truly appreciate it. Great. Next question I have for you, Dr. Nadolsky. It's very general. So let's stick to maybe just today, for example, what comes off the top of your head. So in terms of common fallacies surrounding hormones in the health and fitness industry at the moment, what really sticks out right now to you? What's grinding your gears? Something that's just a complete myth that is being, propagated by so many others in this industry.
Yeah, I'll go with, I think you even mentioned it in your outline, this, and it's really more of a term that it's just in the lay public, and then it's used by marketers of a variety of practitioners, from doctors to naturopaths and chiropractors, but the whole balancing of your hormones. So it's a very frustrating term, because so many times people come in and be like, something's wrong, I think it's my hormones. Well, geez, first of all, do you know how many hormones there are? I'm an endocrinologist. I don't know how many hormones there are. There are hormones we don't know anything about. They're chemical messengers in our body, right? And so as a clinical endocrinologist, I am looking for states of real disease that are causing too much, too little hormone, or maybe something else going on with those same hormone glands. Like we take care of thyroid cancer, for example. It has nothing to do with hormones, really. But all the different hormones we have in our body that do all the different things, they really all interact in a very complex orchestra in harmony. And so to some degree, the system, when we're healthy and everything's functioning correctly, they're kind of balanced. But that term is just so fraught with error. It just doesn't make any sense, because our hormones fluctuate. All our different hormones, and it depends on which hormone you're talking about. There's the diurnal fluctuations, there's the seasonal fluctuations, there's the stress and sleeping and excited fluctuations, and all the different things. Arousal. It's amazing how they're all so there's no such thing as balance. On the other hand, optimizing our diet, exercise, sleep, and making sure, if there is any clinical concern, that there's not a real problem, so that our hormones and our hormone glands and our systems that communicate, our axes, like our hypothalamic pituitary adrenal axis, for example, is all working appropriately, now that's reasonable, but that's making sure that there's nothing really wrong. And then all the other things, the holistic lifestyle stuff, diet, exercise, sleep, stress reduction, all that stuff.
Yeah, I think generally the need to balance hormones is just what I see brought up most often. It can be applied to a variety of contexts, basically whatever you want to kind of sell your point across. A recent example.
It's a marketing term. Yeah, it's just a marketing thing. But then patients, latch onto that, and we just have to talk them down.
Yeah, I think so. A recent example that comes to mind, and please feel free to check me if I speak out of terms, because obviously I'm not an endocrinologist, but I do, clients get referred to me that have hypothyroidism. I have a client right now at Hashimoto's, and I had someone recently who they just got an annual exam. They didn't think anything was necessarily wrong, and they got their thyroid panel back, and everything was basically normal, except that they see a functional practitioner, and their reverse T3 to T3 ratio was out of whack, and they were like, everything else is fine, but this ratio is just really concerning, so you should probably consider going on a thyroid medication. And they were like, I'm not really interested in doing that. I feel fine, but they're pushing me towards this just for that. And I look into it, and the research on reverse T3 dropped off after 2005 because no one was interested in it anymore. And there's a meta-analysis in around 2018, within the past 5 years, looking at, how often this test is being ordered. And it wasn't very often, but for the vast majority of the tests was ordered by a very small proportion of practitioners, which were all in functional medicine.
Yeah, right. So, so you have to understand a little bit of thyroid physiology, so our thyroid stimulating hormone from our pituitary, basically stimulating our thyroid in here to make T4, a little bit of T3. These hormones circulate, they go into the nuclei of our cells. And I tell patients they get things churning and burning, they make things genetically happen. It's our heat metabolism hormone, right? So it actually requires something called deiodinases, these enzymes in different parts of our body, and they're different ones that convert the T4 to T3, because the T3 is what's active. And that's what, so there's always some truth to something, right? And it comes, and by the way, it comes from, endocrinology science, endocrinologist researchers, where they pick something and they decide to go with it inappropriately. And so in different parts of our body, we have these deiodinases. They convert T4 to T3. They also, can go the other way to reverse T3. So when we're under, essentially undue stress, if we're really restrictive, if we're really ill, really severely ill, we'll have more reverse T3, which is inactive essentially, and lower levels of T3. And so a good example of where we could check this. So there are very rare circumstances where, real doctors use this, because one, it's expensive and it takes forever to come back. It doesn't do anything right away. But in the hospital, people can have, especially in the hospital, people can have something called sick euthyroid. So if someone is just really, really, really ill, critically ill, if we checked all their thyroid levels and they're really at the kind of the bottom of the barrel of how ill they are, the whole system will be kind of down. It's called sick euthyroid. The TSH will be kind of down. The T3 will be a little bit, everything will be a little bit low. And then there's a continuum of where this lies. And then if people recover, the TSH will go up, the T4 will go, everything kind of comes back. And so what's actually happening is there's more reverse T3. Now, what we don't really know is, and we don't think this is the case, we don't think that giving them thyroid hormone in that situation helps. You know what I mean? It's the body, kind of just sort of slowing things down a little bit, we'll say. That's a really simplistic, term to throw out there, but that's kind of what the thought is. But people, this has been debated for a while. And so sometimes if you don't really know, if you really think, well, gosh, does this person have a central hypothyroidism or something? Rarely, I mean, I don't know in fact, I've probably never done it. you can order reverse T3. There's also some really rare circumstances. There's one that pops up in the back of my mind because it's on like our board exam, something called a consumptive hypothyroidism, where you get the deiodinase in like a liver, I think it's a liver cancer type thing, where you grow too much of that deiodinase that makes the reverse T3, and you can kind of see that's called a consumptive hypothyroidism, and that can help in that situation. But again, that's an extremely rare situation. And so, can it help decide when to do some sort of supplementation? No, it just hasn't been. It doesn't help diagnose hypothyroidism at all. And in fact, it can give a false sense of security, maybe. There are about probably 15% of people who maybe don't have optimal deiodinase activity to make T4 go to T3. So let's say they have Hashimoto's and they have no thyroid function, or they've had a thyroid surgery, they have no thyroid function, and we're giving them T4. Most people do great. TSH, despite what all the functional docs out there, it really has the best evidence for helping us get it into the normal range that's been validated for outcomes and all these things. But you'll hear some people they just don't feel right. And it seems to be thyroid symptoms. And that's where we get into controversy. And that's where we have to personalize therapy. I personally will talk to patients and say, well, okay, we got to be holistic, optimize diet, exercise, sleep, make sure nothing else is causing your symptoms. And if we want to use a little combination therapy, we weigh the pros and cons, risk benefits, because there are risks, especially as we age. It's harder on the bones and the heart rhythm, stuff like that. But for young, relatively healthy people, I'll say, well, let's do a little bioidentical T3 in there. Let's see how you feel. And we do the best we can. Some doctors think that maybe checking a T3 level, not reverse T3. Oh, I just paused. Not a reverse T3. But a T3 can help, decide that. I actually don't like to do that either. I just say, if we're going to try it, let's try it. We just had a patient the other day, demanded a reverse T3 to see if it would help her make that decision. So my nurse practitioner ordered it, came back normal. So now what's she going to do? We still might try it.
Yeah, a lot of important points there that I feel are worth highlighting, and one of them being is that there's always a hint of truth. There's always some science within these things, right? And that's ultimately what makes them dangerous. What makes them persuasive, and why this field is growing. But it's also why these conversations are so important, to really evaluate and discuss the totality of evidence as a whole, and pointing out that a hint of truth is not always the whole truth, right? So the nuances are something that I know listeners appreciate and love, and you've kind of been pointing to this hierarchy throughout our discussion. We're discussing these potentially rare conditions and these nuances when it comes to hormones, what is balance, the diurnal variation, secretion, and concentrations throughout the day. But really, we need to make sure those basic lifestyle boxes are in check, but before we start attributing anything we're feeling to, these other factors. Is sleep in a good spot? Are you eating a healthy diet? Are you exercising regularly? Because if all of these things are in check, then, well, we're controlling the primary variables that need to be controlled, to where then we can consider, okay, maybe it's something else and we need to look into this deeper.
Yeah, exactly. And by the way, those things are easier said than done, right? I mean,
absolutely.
It's kind of like, we talk a lot about, some doctors, and this is because they might not be in that specialty, where they're like, oh, you need to go, eat better and exercise. Well, that's easier said than done, right? Oh, you need to sleep better and reduce your stress. Well, okay. that's hard. So I always tell people, I'm like, look, I know this is easier said than done, and we got to, find a way, use our resources. If we need to get our counselors, use my dietitians. I'm lucky. I have a psychologist who works in my clinic with us. I mean, I have a great team that I have good resources. Not everyone has that though. And not everyone can afford it. And that's not always going to be, covered or whatever. And that does, I'm going off on a tangent a little bit, but that goes to, well, what about, people think I make fun of, naturopaths and all these other things. But you know what? If a naturopathic physician is just a really good coach and helps people with their diet, exercise, stress, and all the natural things they can do to help optimize their health, boy, that's where we can work together. It's when they do the divide and conquer and start selling them and telling them they have these problems that they don't have. That's where I have a problem. And same with chiropractors. When we all just kind of stick to what our expertise is, we can debate some of the evidence and that stuff. I'm an osteopathic doctor. I know some of the stuff we learned in medicine turns out to not have the best evidence, but man, I have a great chiropractor that he's kind of a sports medicine guy. He basically does like physical therapy to me. I mean, he just sticks with like sports medicine evidence, adjusts me a little bit and it feels great. So, he's not selling any quackery. He does great stuff. And the same goes with doctors. I mean, there are plenty of doctors who've gone to the dark side and do crazy quackery stuff. And yet there are some who are just so bogged down in the dysfunctional system of mainstream medicine that it seems like they're just kind of going through the paces and not doing what we need to do. So, we have problems that we need to work on as a team in the healthcare system in a much bigger way. And again, easier said than done. So.
Yeah, definitely easier said than done. And I couldn't agree more. We can only specialize in so many topics, even within our own space. I mean, when it comes to dietetics, it can be just so vast where, I mean, there are certain people who specialize in working with those with type 2 diabetes. And, we, as dietitians, we can work generally with all these chronic conditions, but sometimes you do need a specialist who specifically works with patients with certain conditions to really optimize outcomes. So the fact that you have a whole team that you're working with, I think that's fantastic, and it's something that definitely is needed when we're trying to maximize patient outcomes. The next topic I want to get to, another hot topic in our space right now, and that is vitamin D. So obviously everything going on with COVID right now, and we have some emerging research on the topic, but there is a fascination with vitamin D that is, higher than it's ever been. And many people are asking, they want to know, I mean, I would like to talk about screening within this. I think it's an important part of the conversation. Most people just want to skip past that and say, like, should I supplement with vitamin D? They're not even concerned where the levels are actually at.
And
but
that's not unreasonable. That's a not unreasonable debate, by the way, because this is tough.
Yeah, I want to get into this where it makes sense for screening, if it's even necessary, and then we can kind of talk about generally about the potential merits of supplementation here.
Yeah. So vitamin D has been, a hot topic, I think, ever since I've gone into medical school. I think it's worth, we don't have to get into the weeds too much, but it is worth people knowing that, first of all, it's not a vitamin, it's actually a hormone. That's why it ends up in an endocrinology sort of specialty realm. And, our skin essentially makes the precursor of it. It's kind of a cholesterol synthesis sort of thing. The sun actually starts that. And then it gets converted in our liver to what we know as, when people talk about measuring vitamin D, what they should be measuring is the 25 hydroxy vitamin D, which the liver makes, and it gets stored in our adipose tissue. And then under the control of essentially parathyroid hormone, so this gets into like bone and calcium metabolism stuff, then it gets converted to the 125. That's the active form of vitamin D hormone that helps with vitamin D absorption from the gut and stuff like that. But it's so from an endocrine bone parathyroid standpoint, it has always historically been that the 25D optimal level is about 32 nanograms per milliliter, because that's when it suppresses parathyroid hormone the most. So kind of thinking of bone health. So that's where you'll see that, sufficiency is kind of, or optimal levels are over 30 nanograms per milliliter. The World Health Organization, I think, says sufficiency is over 20, insufficiency 12 to 20, deficiency less than 12. This goes way back to when people really had deficiencies and they had rickets. In adults, it's called osteomalacia, softening of the bones. They don't grow right. The mineralization of bones is a big problem. But vitamin D goes way beyond just bone health. And we know it plays a role in a lot of other things that way beyond the scope of this, but muscle strength, maybe metabolic disease. So there's a lot of discussion on it for like diabetes risk, like adiposity-based metabolic syndrome, type 2 diabetes risk that we can talk about. And then over the past year, COVID-19, because there have been some, it's always observational studies versus interventional trials, right? So we can correlate things. So vitamin D deficiency especially is associated with all sorts of health problems. And that's where it's like, whoa, something's going on here. It's also a marker of poor health. So the chicken or the egg, right? And so certainly vitamin D deficiency has been associated with like risk of upper respiratory infections and I think pretty definitively for risk of COVID-19 infection and morbidity and mortality, meaning how bad do you get and are you at risk of dying? So then the thought was, well, should everyone just be supplementing vitamin D and making sure we have these high levels? That has not panned out as well. So as usual, and that sort of hasn't panned out as well for like a lot of the vitamin D stuff. So people, especially if you have sufficient or especially optimal levels, vitamin D supplementation hasn't been shown to do like anything. That's why if you look just in the past few months, the USPSTF US guidelines on screening, they say we shouldn't just be screening everybody. But you got to know the nuance. That's screening everybody. People who are at high risk of vitamin D deficiency, maybe it's those of us who live in the northern states in the winter. So I take 1,000 units of D3 if I can remember in the winter. And people with osteoporosis, elderly people who are institutionalized. And then there's a lot of like nuance too with different levels in different ethnicities. Of course, there's a difference of obesity versus not obesity because it's a fat soluble hormone. And at some point, we're probably going to have new reference ranges for different ethnicities and maybe free levels of vitamin D. We just don't have those assays in the validation yet. So for now, we still use the 25D, but that's a very imperfect situation as it turns out.
Yeah, you touched on a lot of points that we could potentially get further into here. One that comes to mind, just because it's on everyone's mind, is the relationship with COVID-19. Like I just got done reviewing, there was a small review on vitamin D levels and the potential benefits of supplementation in older adults. It was 6 studies, but they were all observational, and they found that lower serum levels were associated with an increased risk of complications. And
Right.
It seems like that's something that's consistent right now,
Yeah.
but it is observational, right? So we can't determine the relationship there. Have you seen anything that would suggest that potentially, that the complication itself could be driving the lower levels, if you understand what I'm saying?
Yeah, I don't know about that exactly, but I think it goes back to it being a marker of poor health. So
Mm-hmm.
people who have obesity, metabolic syndrome, diabetes, there's a correlation at least. And again, there's some nuance whether, optimizing it may help with these, and it might in some ways. But there's definitely a correlation of low vitamin D with obesity, insulin resistance, type 2 diabetes, cardiovascular disease. And so there's so many confounding variables because those things are what we know for sure put people at risk of harm from COVID-19. So it's very much an adiposity-based sort of disease prediction. So people who have increased adiposity and obesity, even if they don't have any complications of it, they're at increased risk of at least getting very ill from COVID and dying. If you have worse obesity, and by severity, I mean staging it based upon, do you have metabolic syndrome, type 2 diabetes, heart disease, et cetera, you're at even higher risk of dying from COVID-19. And so that's where it gets hard to say. And vitamin D supplementation, the actual interventional trials, haven't panned out to seem like they're helpful. There was some evidence that I cited for I think I did an interview for like AARP last year when this all came out. There was a 2017 evidence meta-analysis that suggests that maybe getting vitamin D supplementation could have helped with like reducing asthma exacerbations, protect against URIs, and that's if you're deficient, of course. And so with COVID-19, I'll tell you what I tell people is it's probably reasonable just to take 1,000 units of D3 a day if you're not getting enough sunlight or getting it in your diet. Because there's really minimal harm unless you take too much. And by the way, we do see that, so don't take too much. And it's not that expensive, and there are so many possible little benefits that maybe they add up to be beneficial. We just can't say it's the magical supplement we always thought and hoped it would be, unless you're deficient. If you're deficient, it's probably pretty beneficial in a lot of ways, both for bone health, maybe that cardiometabolic health, maybe even preventing some of the diabetes stuff. there's a lot of mixed data on that.
Yeah, I'm totally on board with you, and that was going to be my potential follow-up question, because I know the listeners are going to know. They're going to say, okay, yes or no, should I be supplementing with it, and then like how much? And I agree with you. I think that, you know, in the vast majority of cases, 1,000 IUs, you know, a minimal dose to cover your bases, especially depending on your diet, because we know that, you know, depending on whether or not you go outside, again, depends on where you live, but in terms of diet, like nobody is getting nearly enough vitamin D through diet alone. You know, some NHANES data shows that, and again, there are some issues with this data and self-report, but like 95% of people aren't getting anywhere close, you know, to the daily recommended amount. And I review diet logs all the time, and 10% of daily value is something I see very consistently for vitamin D. So yeah, I agree with you there. All right, Dr. Nadolsky, the last question I want to get to for us is continuous glucose monitors for healthy people. This is, you know, all of our topics today, hot topics, very popular at the moment. CGMs are kind of like this Silicon Valley ideal for, you know, biohacking your health and optimizing things. I see articles every day. They're trying to get this into like Apple Watches and just be part of everyday technology. But when we look at the data on, so I should back up and first ask you about glycemic variability before we get into the data on this, because this is where the concern lies, right? I mean, I constantly see on Twitter specifically, and just nutrition social media, like this fascination with the postprandial glycemic response, especially in the low carb space, right? Like any elevation in blood glucose following a meal whatsoever is like this negative thing and should not be happening. And I think that's kind of a questionable take. But I want you to tell the listeners what glycemic variability is, and more or less like what's a reasonable or healthy response, postprandially speaking, to a bolus of carbohydrates.
Yeah, so you know, I'll tell you first of all, because where we get most of these data are from people with diabetes, both type 1 diabetes historically, and unfortunately the rising you know, percentage. Most people have type 2 diabetes, and these are, you know, very different physiologies. But you know, a normal fasting blood glucose is under 100 milligrams per deciliter. A normal post meal, you know, within 2 hours, is less than 140. So when we have people with diabetes, depending on how they're being treated, what if they have type 1, type 2, or some other different type, you know, we might have an intensive fasting goal of less than 110, or a postprandial meal goal of less than 140, or more relaxed, and we'll say fasting less than 130, or 2 hours less than 180. And it's because we have data that say when we keep glucose levels within those ranges, and this is long before we had CGM, but, you know, checking the sugars a lot, basically, then, you know, that reduces the risk of microvascular disease, eye disease, kidney disease, nerves, gastroparesis, all those things that we think about with chronic hyperglycemia. It's not as helpful for like cardiovascular disease, but there's something to that, okay? So glycemic variability is essentially the standard deviation of your average sugar. So a continuous glucose monitor will give us your average glucose. Now, notice I'm not saying blood glucose, because this is in the interstitial fluid, right? And so it's actually different than checking blood glucose, and people don't necessarily get that. And there is a lag time. And by the way, none of these things are perfect, right? So meters that check the blood glucose are going to be a little bit off from, like, if we got a lab that checked glucose, you know, a real lab, and then continuous glucose meter differences are going to be a little bit off. And so they have to even get approved, they have to be within a certain range of what's actually accurate. Okay, it's called the MARD, for what that's worth. And so the variability is the standard deviation away from the average. So with type 1 diabetes, you know, we really would like to see people spend most of their time between a glucose of 70 and 180. And type 2 diabetes, by the way. So that's time and range. Okay. So that's like, we really want people to be well over 70% of the time there. And, if you have gestational or pre-gestational diabetes, when you're pregnant, we're even more intense. Okay. And then of course we want to minimize hypoglycemia. And that's for people who are on insulin, like with type 1 diabetes, et cetera. And so the variability is how much away from your average do you get? Well, a healthy, fit person, their average sugar, their average glucose is going to be, could be in the 70s, could be 80s, 90s. Obviously, it goes up if you eat some carbs, but then it comes right back down, and you don't have a lot of variability. So a really healthy person, their variability based upon something called the coefficient of variation is going to be, anywhere from like 5 to 15 or so. And I'll tell you, the goal for like someone with type 1 diabetes is to be less than 36%. And so let me cite a study if anybody wants this. Continuous glucose monitoring profiles in healthy, non-diabetic participants, multi-center prospective study. A lot of famous authors on this. This was in the Journal of Clinical Endocrinology and Metabolism, 2019. And this was using a Dexcom G6, probably the best one we really have right now. And the, let me see here. So the mean average glucose was 104 milligrams per deciliter, which is nothing, by the way, for an average. And the coefficient of variation that I just mentioned for the variability was 17%. I think when I did it, because we all do this in training, mine was much under that. And my younger brother, who does family practice and is like social media giant, that's like his job now. He's a memeologist, we call him. He just got one just for fun to test his, and I think it was like 12%. This is nothing. This is clinically meaningless for the average fit person. You're not going to have high levels of glucose. In the study I was talking about, the median time spent with glucose levels over 140. So remember, I talked about that's really kind of the upper limit of normal. If you don't have any disease, was only 2%, 30 minutes a day. And I'll tell you, Spencer, my younger brother, he was really trying to make it go crazy with all sorts of high glycemic index carbs and whatnot. So it's really beneficial when people have insulin resistance or they have, pancreatic insufficiency. I trained with a mentor who was studying all this stuff. He's published a lot of these data for the past 20 years. And he was really kind of on the brink of showing benefit for those with pre-diabetes to help with their diet, to help some of that glycemic excursion, to help them with their dietary efforts. There were some study flaws and stuff like that. And I don't know that we ever came to that great of a conclusion, but it certainly, I can tell you in reality, does help people who have, diabetes, especially diabetes mellitus. But healthy people, I wouldn't do it. I'll tell you, it just gave me anxiety when I was wearing it. I was like, hopped up on coffee. Why is my glucose almost 100? And then everyone was like that. All the endocrinology fellows were like that when we did it. We're all, coffee makes your sugar go up, by the way.
Yeah, no, I love that context. Personally, I use the good old finger prick method. Why? I don't know. I like data. I like seeing these things. I have a log of like, close to 50 entries of me eating different foods. What happens when I consume it at breakfast? What happens if I consume it post-workout? And it's like between all of these different things, like there's barely any variability. Right. And like I've learned nothing from doing this. I've learned that, I confirmed my hypothesis. I'm metabolically healthy and I can handle a variety of carbohydrates. And as you outlined, for anyone else in a similar position, you probably don't need a CGM to quote unquote optimize your health or biohack it or whatever the latest term is.
Yeah, I think it just causes more anxiety. And remember, people need to remember, these are not perfect. People think these labs and everything's perfect. God, there's so many things that cause problems and error. Like, it's hard enough when people actually have a problem that we're addressing, let alone just doing it for fun. And it just causes more anxiety. I mean, it's kind of like people going and getting all these different crazy lab work hormones done by their functional doc, or just order them on their own. And then they get referred to us because they don't know what to do with the results. And then we get mad, but we have to talk them through it and figure out if something's wrong.
I think it was Kevin Hall who had like a short review on this. It might have been titled something like "In Precision
Hmm.
Nutrition," and
Yeah,
it
yeah.
was looking at Dexcom. And what's the other popular
Yep.
one? Is it Freestyle
There's a
Libre?
Freestyle Libre. Those are the two most common commercial ones right now that we have. Yeah.
And even those were like significantly,
Oh
statistically
yeah.
speaking, different, right?
Oh yes. Oh, it's yes. You
Yeah,
have to be able to use these in a clinical context. It's going to drive people crazy if they do them just for fun, I think. But it's there's not a ton of it. I mean, it's not like taking a medicine that might have
right.
harm, I guess.
Hmm.
But it's and then we have tons of people that have diabetes that really, really, really need these, and then they can't get them. They can't afford them, or
Hmm.
the insurance won't cover them. And so I don't know how, people are biohacking and stuff with these. Now, I suppose if capitalism found a way and it reduced the price because everyone was buying these, or, I don't know. I don't know if that would go the right way or the wrong way, if it would help reduce costs. But anyways, we need to get them for people who really need them.
Yeah, absolutely. I think that would be the only benefit, if somehow streamlining these
Mm-hmm.
devices could get them in more hands of people who actually need them. Um, Dr. Nadolsky, that's all I got for you today. This has been a wonderful chat. I really enjoyed it. I know the listeners are going to get a lot of out of it. For those who want to go learn more about you and support you, where can we point them towards?
Well, you can find me on, Facebook at Dr. Karl Nadolsky, Instagram, Twitter. Try to do a little TikTok. Those people hate me. And our website, docswholift.com. I struggle to keep that updated. I need some help, but once in a while we put some stuff on there. And sorry, my face paused in such a attractive fashion. That seems to be par for the course, I guess.
I'll see if I can do some editing for YouTube, and when it pauses,
All right.
maybe we'll throw something else up in there.
Yeah, sounds good.
But all of those links will be in the show notes. Highly encourage checking out Dr. Nadolsky on social media. Love his stuff, debunking, the myriad of myths we have in this industry on a regular basis. So it's something that's much needed. But everyone, that does it for another episode of the Muscle Memoirs. Thank you so much for listening.